Hello, everybody. I'm glad to be here. And I just came off the plane and I came here. They told me I had to talk, so I'm going to talk. All right, so I'm gonna fill in for Dr. Dluhi, and I'm going to talk about craniocervical instability. I've done some craniocervical fusion, so I'm not that much out of my element. The craniocervical junction is the point of conjunction between the spine and the skull. Since all of you know what Chiari malformation is, or at least you have heard several times, you know what's this anatomical location. Now, what are the players in this location? What's the cast? There is the cervical medullary junction, which is the junction between the brain and the spinal cord. There is the craniocervical junction, which is the bony box which contains it. There is the cerebrospinal fluid passing by, and there are the arteries feeding all this area. So, picture on the right is the MRI, the nose, you know what it is, the mouth, you know what it is, and you see the big worm coming up is the spinal cord, and it transforms itself into the brainstem that then spans out in the brain and the cerebellum. On the left, you see the brainstem in all its glory, and the lower part in orange is the medulla oblongata, which is so funny to be pronounced. And through that area, which is the medulla oblongata, which is so small, there is a bunch of stuff passing by. Lots of traffic up and down. Practically everything which is in the skull passes through there on the way to the spinal cord. So everything which is the point of communication, the highest point of traffic between your brain and the rest of the world passes through the medulla oblongata. So it would be very, uncomfortable if something happened to it, like some mafioso would say. To make things are more complicated, the brainstem has some nerves and centers of its own, which makes this region even more vulnerable. This is the skull. I took the freedom to cut the skull from the top, so you see what is called the Foramen magnum, which in Latin means the big hole, so it's not very imaginative of a name. And through that hole, you have to stuff the point of communication between the spinal cord and the brain. The cerebellar tonsils, if you decide to have Chiari malformation, cerebrospinal fluid plus arteries passing back and forth. So all that is passed through this small hole, which is like this. So not a great idea. Cerebrospinal fluid is passing by. It's like everybody says is the lubricant for the brain. Actually, is also a sort of an open air sewer. So, like in the old countries, people were throwing the urine and the chamber pots out of the window in the streets. That's pretty much what happened to the cerebrospinal fluid. The brain does not have a sewer of its own. So everything that the brain produces in terms of waste products, just they piss them off inside the CSF and it passes around until it gets reabsorbed, clear up, and rinse, repeat. Then there are also the arteries passing by. The arteries are important. Without those and without the veins getting the blood out in the opposite direction, your brain dies, which again is not a great idea. Now, all these pieces of bone, the skull, the spine, by themselves, they would be a very precariously built Jenga castle. So the good Lord put together a sturdier complexion and united all these pieces with ligaments, which are practically glorified rubber bands organized in many different directions in order to allow you to move. So you can see up, you look down, you look on the right if Angelina Jolie passes by, or on the left if Brad Pitt passes by. The reason why they're apart is that they're divorced. Now, these ligaments are going in every direction, and there is sort of redundancy. So it is not just like a city kind of construction. It's like a private, it's a private company kind of umbilical structure. So it's done well. There is a lot of redundancy. So if one ligament fails, there are the others kind of take over. But what happens if you are not built right? What happens if something happens to that joint, which can be congenital, can be acquired, can be a tumor, can be a trauma? At that point, as you see, the inferior part of the brainstem, the medulla oblongata, gets it literally on the chin. So imagine all those cables passing by, get stretched, not a happy situation. In this case, also, this patient decided also to stuff on the other side the cerebellar tonsils because he has a complex Chiari. So now the cerebellum is the medulla oblongata is getting on both sides. Now, so far was kind of fast. I'm gonna slow down just to explain what is clinically about the craniocervical instability and the thing. So it is a little bit of a 102 level for a patient, so you're gonna sound smart when you go online. Now, what happens if you have a picture like this? Sometimes, surprisingly, nothing, because not all the brains are the same. So you get Mike Tyson, okay? And he punches two people. Punches me, I'm out for the count for 40 days. Punches another guy who's the heavyweight champion of the world at this point, and the other guy can't take the punch and they can keep fighting. Same punch. So same situation, same anatomy, looks horrible on both MRIs, looks carbon copy on both MRIs. One is very sick with a lot of symptoms, the other one walking around like nothing happens. The brain of the second person can take a joke, the other one is more touchy-feely. And that's exactly like this. So looking at the picture like this not necessarily means that you have to cancel Christmas, you're gonna have 300 surgeries. No, it depends on a combination of symptoms and anatomy. And now we go to the symptoms. Cervical medullary syndrome is, again, we doctors like to have very long words. It's just like, how is your brain feeling because of this? Now, you understand that if I am dropping something heavy on your foot, you're not going to have pain in your ear. It sounds very stupid, but that's what cervical medullary syndrome is about. So remember all the cables passing by, all those scents inside the brainstem. So cervical medullary syndrome means this. Syndrome is a collection of signs and symptoms. Sign is something that everybody sees, like I cannot move my arm. Symptom is something I feel. Oh, I have a headache. What if you don't? Okay? But that's a collection, syndrome. So what's a cervical medullary syndrome is the collection of signs and symptoms which are typical for what's happening here. And it doesn't really matter what is causing it. Okay, it can be a tumor, can be congenital, can be a trauma. What happens here produces a monotonous sum of signs and symptoms, sometimes more severe, sometimes more mild, sometimes nothing. All right, clinical presentation depends on all these symptoms you see there. It can be headache, can be paralysis, something wrong with your eyes, and the ways the eyes function, they move, the equilibrium, blah, blah, blah. We keep going. And that's a reflection of all those traffic of cables passing by. The pathologies, many things can do the same, like you have a massive, motor vehicle accident at 80 miles per hour against the wall. Guess what? Your head is going to almost detach off your neck, or is going to detach altogether. It's called, Craniocervical, what's the name? Now I'm going to forget. But anyway, you can have internal decapitation, which means your head flops around, there is no bone, no ligament keeping it, and you're just, only the skin keeps it together. So traumas, tumors, a big infection, inflammation, congenital malformations, like a complex Chiari 1 malformation, vascular events, blah, blah, blah. What's a complex Chiari 1 malformation? Is when you have Chiari 1 malformation plus something else. So if you have a a big abnormality of the craniocervical junction. Plus Chiari, you have a complex Chiari, and you're out of luck because it's more complicated to take care of you. Now, key differences. Now, you're going to have the same target, which is here. You're going to have the same symptoms, but they have a different flavor. So trauma is something harsh, fast, hard. Other pathologies, they're a little bit more slow, and they go on simmer, okay? Like congenital malformations, they do that. Now, you remember the pictures before? That's self-evident. So it's congenital, it's structural, you know, like you really stick like a sore thumb if you have that. Iatrogenic is a Greek word to say the doctor made a boo-boo, okay? So if during a surgery for Chiari we remove too much bone, if you compromise the tension band C2, which is another thing, or say we got too much stuff over there, or if you remove too many muscles and then we're not attaching together correctly, we create instability because your head becomes wobbly on top of your neck. Functional. The anatomy looks okay. Look at the MRI, looks okay. Nobody touched you ever surgically, but the ligaments are wobbly because the ligaments are supposed to keep everything together. If you have something which is wobbly, the bones are going to do like this. So the anatomy is rather normal, but the ligaments are defective, and congenital pathologies affecting ligaments are called connective tissue disorders. And the Ehlers-Danlos syndrome is the most common. Now, the only thing I want you to remember for the day, so you're going to look even smarter with your friends, EDS, Ehlers-Danlos syndrome, is not a disease. It's an evolutionary advantage that sometimes becomes a disease, okay? So if you are the captain of the football team or the most beautiful woman in the school, do you think that you have a disease? Hell freaking no. All these people have Ehlers-Danlos syndrome. All these people have a congenital mutation which makes their skin very smooth. They are sparkling when they come in front of you. They're extremely athletic. All the people at the Olympics, in gymnastics, in track and field, they all have this congenital mutation. All the supermodels have this congenital mutation. Now, an EDS specialist feels sorry for me when a supermodel starts having instability because they come in. So these are people who are even more than human, and they're not sick. But sometimes this problem becomes pathologic, okay? So this starts giving symptoms. That skin and those ligaments which are advantageous now start falling apart. And you start falling apart in certain parts of the body, at that point you start having a series of problems which are part of EDS. I'm not going to talk about this. I'm just saying, if the EDS hits your craniocervical junction, the ligaments keeping the bones there, you're going to have a wobbly head on top of the neck. And this can also be made worse by a bunch of other things I'm skipping. Now, there is a difference, and again, another pearl to sound smarter, there is a massive difference between hypermobility and instability. All the people in the circus who are contortionists, they all have Ehlers-Danlos syndrome. They're not sick. They can do all those things without any symptom. These guys can check their own tush without the help of a mirror. They can just rotate. They can rotate up to 250 degrees their head around with zero symptoms. Obviously, if you have somebody who's moving that much, is not unstable, is hypermobile. Instability means you move too much and you say, ouch, okay? You move too much and that movement gives you a problem. The paradox is that if you have a patient coming through the door and say, Doc, I'm unstable, and does all these things, 270 degrees, whatever, is not unstable. The guy with EDS who comes to you and says, Doc, I'm in trouble, he would rather be shot than moving his neck, because moving the neck that before was doing so fluidly, now moving a little bit gives him horrible symptoms. This is the difference between hypermobility and instability. Now, other thing, you can be unstable in multiple directions because this joint is not like the arm does like this, but it can go in 3D. So you can have a vertical instability, horizontal instability, a rotational instability, or a combination of the three. I'm not going to tell you any more stuff, otherwise you're going to sound too smart. Now, there is a difference between kids and adults. And what's the difference? In craniocervical instability, all the pictures, the anatomies which are the most messed up, get fished by the pediatric neurosurgeons first, because the more messed up is your anatomy, the higher the chance that that brain cannot take it, okay? On the other hand, then the congenital anomalies which are more mild, they're going to be caught up later by the adult neurosurgeons. It's the mother-in-law principle, okay? If you have a mother-in-law who's nasty, you're going to tell her shut up probably within the first month. If the mother-in-law is annoying and you're a saint, probably you're going to wait 10 years before you tell her, okay? So what's the difference? The pediatric craniocervical joint is like a growing tree, not going to become poetic, which is as he gets older, he's actually getting sturdier, okay? The kids are more flexible, but then become less flexible as they grow up. On the other hand, the old guys, I was going to say the old farts, but the old guys, as their joints get older, if they have a problem, they're like the hinges of a heavy door, and they're good in the beginning, but then they start falling apart more and more. So the kids, their joints, they're super mobile, and then they're getting normal and better. But if you have a problem as an adult, you start falling apart again. So it's an arch. Now, the diagnostic criteria of craniocervical instability, this slide is just to show you, is not only the picture, okay? It's not only the MRI. On the MRI, you can be wrong, because you can have an MRI looking horrible and the patient is fine because the brain can take a joke. Or you have an MRI that looks good, but the patient has horrible ligaments, okay? So it has to be a combination of things in order to reach a reliable diagnosis. And then some more. You have to do also additional testing. So this is the junction between the base of the skull, the first vertebra, which is in the middle, and the second vertebra. This is just in one direction, so it's much more complicated than that. But you understand that if this is a normal movement, if somebody becomes unstable, all these things are going to flopping around. So what we want to do, since the care for this joint is pretty barbaric, we put screws and we fuse the damn area. From he's moving too much, now we're going to tell him, no, you ain't moving anymore. So we put screws, but if we put screws, those segments are going to still be moving, and then we connect it with bars. It's very rudimental. It's the same thing you would do at home if you had a table which is falling apart. You put a couple of screws, you wrap it around. And there were different kinds of fusion surgeries done in the past. Fusion surgery, they've been done for several decades, and they have evolved technologically over the years, but it's the same principle. You want to keep it together as something that is moving too much. This is the bar plate configuration. This is the way it looks on an X-ray. You can fuse shorter, you can fuse longer, certain kind of screw trajectory. But at the end, what you want is a combination of things, the same you would have in a pillar of armor cement. You want metal and you want bone. In a pillar, you don't want just the metal, otherwise it would bend over time. You don't want just the cement, otherwise it would chip apart and it would get brittle. So you want the sum of the two is better than their individual. So you want good fusion between the two. Now, there is a dilemma if you have, because this is a Chiari conference, if you have Chiari and craniocervical instability or a craniocervical malformation, there is a dilemma there, because Chiari surgery requires the bone to be removed to get in. As I told you, craniocervical fusion likes to add bone. On the other hand, craniocervical, the Chiari surgery, you sometimes want to open 1 or 2 vertebrae. You want to put screws, so whatever, how much you open. But the biggest thing is the hole in the back of the skull. If you have this kind of thing, and the upper half are the screws to the back of the skull, and if you have a big hole there, where you put the screws? It's not polite to put the screws in the brain. So about that, or if you have Chiari malformation, very often you have a very thin skull, paper chip. So if you have a 1 millimeter skull, and the shortest screw you can put there is a 6 millimeter screw, problem. So there is some way to get around. You can put screws underneath the skull, which at the end is a craniocervical fusion, but it's just shorter. And then, you put bone around it. So now you can see the hole, and the screws are missing the hole. Now, what you want at the end is to fix the problem. If you have a complex Chiari, you want to decompress the Chiari from the back and to fix all the bones around. So, recapping. Craniocervical junction is a part of the anatomy. If it falls apart, we put it together. It's not rocket science.